Hello and good morning everyone. This is Dr. Hari from Cell Tissue Technology. Today I'll be speaking a little bit about tissue engineered human skin, mainly autologous and allogenic human skin. So just to clarify, tissue engineered human skin is actually human skin that is manufactured in a lab. It may sound confusing at first, but let me try to simplify it as much as possible. What we usually do with tissue engineered human skin is we get a sample of human skin from any donor. Could be the patient, could be a non-patient, and we take that small sample, we break it down in the lab to its cells, and then we expand the cells, we culture them, and then we construct the skin according to the size needed by patients. So the two main types that we are generally dealing with are autologous skin and allogenic skin. Autologous skin refers to skin from the patient themselves. Allogenic skin refers to skin from a donor. Now, both these products are good because tissue engineered human skin is meant to fill the void that has been around for quite a number of years when it comes to managing chronic wounds. The current management of wound care is already very good, but it is limited by a few things such as cost, constant readmission, and also lack of numbers of professional healthcare people who can absorb the workload. And the number of increasing patients yearly is also not helping this condition. So what we try to do with tissue engineered human skin is we provide an alternative for patients who require management in a slightly different way. Say for example, a patient has gotten a half body burn, 50% burn. Now, the standard method of treatment logically would be to try cover the entire area with human skin. Using the standard procedure such as split skin grafting, it would be highly unlikely to take another 50% of healthy donor site and put it over as coverage for the affected site, thereby creating a new wound site. So with all these points taken into consideration, this is where tissue engineered human skin comes in. We have two types, autologous and allogenic, as I mentioned before. They're both good and they can be used for varying situations. Autologous skin being from the own patient itself, what we do, like I mentioned earlier, we take a small sample from the patient and then we construct a skin that is the patient's own one and we implant it back to the patient. So the skin is from you back to you. This is good because it reduces, number one, chances of rejection when you use the product. And once there's less rejection, automatically there's better uptake. And the wound edges tend to join together with the tissue engineered human skin quite well because it is the own patient's skin. So the signaling patterns from this piece of skin and from the surrounding wound area will tally with each other. So the chances of rejection will be very much less. And aside from that, we can also customize the thickness of the autologous skin. For certain patients, they may have superficial wounds, so we can provide thinner tissue engineered autologous human skin. There are also patients who have deeper injuries like in third degree burns. So in cases like that, we would have to construct a bi-layered skin to cover all the loss of layers. So this is doable with tissue engineering. And our allografts or allogenic skin are generally from donors, and they are healthy, viable donated skin that are stored in cryopreservation until there is need for the skin to be used. So this skin, while it is a donor skin, the skin's function is mainly for temporary coverage because the allograft or allogenic skin is not the patient's own skin. So the moment you put it over the patient's wound, its main function would be to just provide closure to prevent infection that usually arises from prolonged exposure to the external environment. So in situations like this, where you need faster coverage and the autologous skin is not required, you can always opt for allogenic skin. You can construct it quicker and you use it for a shorter period of time, especially among young patients who tend to heal more rapidly. In conclusion, what we have with tissue engineered skin is basically a solution for a lot of ongoing long-term issues with chronic wounds. So the hope is that in the future, using our autologous and allogenic skin, we will be able to cover patients who generally are left out by the system due to limitations that exist in the management of wound care. That's all for now. Thank you very much for your time, and if there are any questions or queries, you can always go to our social media, Facebook and Instagram at Cell Tissue Biobank, or you can also go to our website at www.celltissuebiobank.com.